Welcome to the IVF Journey with Dr. Michael Chapman, the podcast for couples who struggle with infertility and want to fulfill their dreams of becoming parents. In this podcast, you'll learn actionable strategies to deal with infertility from Dr. Michael Chapman, or Prof as he's affectionately known. Prof is the co-founder of IVF Australia and is a leading Australian infertility specialist who has helped over 3,000 couples realise their dreams of becoming parents. To access previous episodes packed with ideas, solutions and tips that actually work, head over to Dr. Chapman's IVF podcast on iTunes. You can also ask questions by contacting Dr. Chapman's rooms on 1800 111 483 or by emailing him michael.chapman@ivf.com.au.
That first cry of a baby born after the long journey of IVF remains one of the most beautiful experiences in the world. As an obstetrician and an IVF specialist, I've had the privilege of experiencing this over many thousands of times in my long career, but I still remain moved by each baby's first cry. It signifies the end of a long journey and the beginning of a new life. This is Professor Michael Chapman, co-founder of IVF Australia and host of the IVF Journey podcast. Thanks for tuning in. To access all the previous episodes, head over to my website, www.theivfjourney.com, and select IVF Journey Podcast from the navigation menu. You'll also be able to find the various services that we provide at IVF Australia. So today we're going to talk about a variety of topics, but predominantly related to things that patients have asked me in the last little while about their potential causes for infertility and some of the stories that they've heard about particular tactics to improve their fertility. So let's start with painful intercourse. This usually comes up when I'm taking a history from a patient, and one of the questions that I generally ask is how often they're having intercourse and is there any problem with it. The woman will then say, I get pain when we have sex. Is that a possible cause of her infertility? Well, obviously it is to some extent, because if a woman is having painful sex, she's not going to be very keen about having sex. So therefore, in itself, may reduce the chances of pregnancy because of lack of exposure of sperm getting near the eggs. But on a more serious note, it may reflect pathology within the pelvis. So the particular things that we think about in relation to that are endometriosis and pelvic inflammatory disease. Generally, if we get that history and there are other symptoms that go along with one or other of those, I would be recommending having a laparoscopy to either exclude or find the diagnosis. And if we do find scar tissue related to either of those two, then we can remove it at the time of the laparoscopy, hopefully improve the painful sex, and hopefully then result in pregnancy. Painful sex can also be psychological, that a woman that's had some experience in the past of having painful intercourse or painful vaginal examination can result in a block in her mind about the enjoyment of sex, and that then results in the failure of lubrication, and therefore when sex occurs, it is going to be painful because the normal lubrication isn't there. Psychosexual counselling is very important in this area. The next question we're going to deal with is that one of positions. Again, that sometimes can come up when I've asked that question about how often they're having sex and are there any problems with it. And I certainly get patients who say, their girlfriend said that if they lie on their back with their legs in the air, or that they have sex in the doggy position because the sperm will stay there longer. They're the sorts of questions that people ask, but they're all garbage. It actually doesn't make any difference whatsoever, position or what you do after having sex. And the fact that there is secretions, semen that drips out of the vagina at the end of intercourse is totally irrelevant. There's enough sperm at the top of the vagina. That's all that's required. So dismiss that question. Then there's the question about lifestyle. My husband drinks too much. Well, what's too much? Sometimes I just joke and say, well, as long as you're not drinking more than me, you're not drinking too much. But really the answer to that question probably is anybody that has more than a couple of beers every night is probably drinking too much on the male side. That's what I'm talking about. How much alcohol interferes with sperm is really debatable. Certainly excessive, and that means getting drunk a couple of times a week is not good for your sperm count. And on the female side is almost certainly not good in terms of the safety for your baby in the pregnancy. But having 1 or 2 glasses of wine 2 or 3 times a week, in my view, is absolutely fine. Everything in moderation. Other lifestyle issues that I get asked about relate to exercise. There are gym junkies that come along to see me, wives who spend 6 days a week, 2 hours a day so they keep them slim and trim and beautiful. Is that interfering with their chances of conceiving? There's certainly evidence that excessive exercise with weight loss inhibits ovulation, and therefore you can overdo it. Female Olympic athletes, often their periods stop during times of intense training. So certainly excessive exercise is a negative thing. To start doing exercise to lose weight is a good thing, but once again, you can't get obsessed by it or you'll do yourself harm. On the male side, exercise is good. Again, excessive exercise can be an issue in terms of suppressing sperm production, but that really does have to be quite excessive. The commonest reason for the male gym junkies to have low sperm counts isn't about their exercise, it's the taking of anabolic steroids. And I think in most gyms you can find black market gonadotrophins, black market growth hormone, black market steroids to make that beautiful muscly body that will appeal to the world. The problem is it also they all suppress sperm counts. And while most will recover, the occasional patient who's become azospermic, producing no sperm, and it never comes back. And the only thing we can find has been long-term use of anabolic steroids. Sadly, this issue is a growing problem as men become more narcissistic, as men believe that their bulky bodies are in some way attractive to the rest of the world. I can say this as a middle-aged, slightly obese gentleman. But anyway, other lifestyle things, well, everybody knows that smoking's bad for you. That smoking in females on a regular basis brings forward the menopause by an average of 4 years. What that's saying is that egg quality is declining at a faster rate when you smoke. So that's a very bad thing. In the male, there's a good evidence that smoking is associated with DNA fragmentation, that the DNA in the sperm head is more deranged in people who are smokers. Now that's cigarette smoking. There's also increasing evidence that smoking dope, marijuana, is associated with reduced semen quality. So recreational drugs also are an issue in infertility. The other thing that gets laboured a lot is weight. Is there a problem with being overweight and trying to conceive? Well, there definitely is, in that miscarriages are definitely more common in women who are overweight. And it would seem that overall women who are overweight ovulate less regularly and therefore their fertility is going to be impaired. That group tend to be in the diagnostic group of polycystic ovarian syndrome. And there's debate, if you don't have polycystic ovarian syndrome and you're overweight, is there really any difference in the outcomes? Certainly in mice who don't have polycystic ovaries, if you have obese mice, their eggs are poor and therefore their fertility is lower. That may be the case in the female. We've certainly shown, looking at a fairly unique method of assessing egg quality, we've shown that elevated BMI reduces egg quality based upon the genetic structures within the egg. So in general terms, one has to say, don't be overweight if you're trying to conceive. It will add to any other problem that you may have. The evidence in the female is that you don't need to go from 100 kilos to 50 kilos to be improving your fertility. If you can go from 100 kilos to 90 kilos, you will get improved fertility. The evidence is there. Randomized controlled trials suggest that between 5 and 10% weight loss is very beneficial. So don't necessarily think that you have to rush out and lose vast amounts of weight. On the male side, and I don't think I very often get men asking this question, although I think I've had one or two women ask about the size of the men's balls, that he's got small balls, does that mean that he's going to be infertile? In most cases, that's not the case. You have to have very small testicles and fibrosis within them to actually have reduced sperm counts. We do find that, and we find it predominantly in men with chromosomal abnormalities. But they're relatively few, and they're usually associated with no sperm at all. But in general terms, the range of size of testicles of most men, it does vary, but got to have very small testicles for it to be an infertility problem. The other thing related to the male and to a specific condition that causes no sperm to be ejaculated is called cystic fibrosis. So cystic fibrosis is that condition affecting the lungs, particularly in children. It starts at birth where the secretions are much more tacky and they can't get rid of the sputum, and that can cause severe respiratory problems. That's caused by a genetic abnormality in the parent, and if the male is a carrier of that genetic abnormality, that's more associated with an anatomical problem called absence of the vas deferens. So the testicle can't connect to the penis, the vas is absent, so sperm can't get from the testicle to be ejaculated out of the penis. Again, very rare condition, but if someone has a history in the family of cystic fibrosis, we certainly go looking for the underlying gene problem to make sure it's not there. So the next question I get asked is about pregnancy after a woman has had tubal ligation. I'm usually asked this question by couples where the woman is usually in her late 30s, early 40s. She's had children in the past with one partner, and now she's separated and now has a new partner, and they're wanting to have children. She had a tubal ligation because she thought she'd never want to have any further children. And the question that I'm asked is whether they should have the operation to reverse the tubal ligation or whether they should have IVF straight off. For women over 40, I certainly have a view that IVF is the way to go because you are moving very quickly to produce a pregnancy. And for women over 40, time is running out. For women under 40, reversal of sterilisation should be considered. However, success rates after reversal of sterilisation are dependent on the type of sterilisation performed and the amount of damage done to the fallopian tubes. The commonest form of tubal ligation of the last 10 to 15 years has been putting clips on the tube. These only damage 3 or 4 millimetres of the tube, and therefore cutting them out and joining the ends together is reasonably successful. What do I mean by reasonable? Probably 50 to 60% of women who have a reversal, if they're under the age of 38, will conceive. Over 38, the numbers drop off just as natural fertility drops off. So for some women, particularly those that want to have more than one child, having a reversal may be the right way to go. The problem after that, if they have been fertile, however, is they then have a contraceptive problem because they may not want to have any more babies, but they've got open tubes. The other downside of reversal of sterilisation is an increased risk of ectopic pregnancy, which can be life-threatening. You can avoid that by doing IVF. A similar question arises in men who've had a vasectomy. Again, they tend to be men in their early 40s who had a family when they were in their 20s and didn't want any further children and therefore had a vasectomy done. Their marriage is broken up. They then decide with their new partner that they want to have a baby. What should they do? Should they have a reversal of a vasectomy, or should they go to a procedure of sperm extraction and using that sperm to carry through with an IVF cycle? The balance generally, I would say, is towards doing the IVF route with surgical sperm extraction. The reasons for saying that is that while we can correct the anatomical abnormality, in other words, the tube's been cut and tied, we can join the ends together. It's not as simple as in the female. The longer it is from a vasectomy to the time we try and reverse it, the higher the levels of something called sperm antibodies. So the body produces chemicals, a bit like they do when we have an infection, to attack the sperm. They bind to the tails of the sperm and they bind together. So it's a bit like tying their legs or their ankles together. They can't move, they can't swim. And so pregnancies after reversal of vasectomies are relatively low. The literature is very wide on this in terms of the numbers, but some people quote as low as 30% chance after vasectomy. Others claim over 80%. Certainly over 80% will get sperm in their ejaculate, but it certainly won't guarantee a pregnancy, predominantly because of the sperm antibodies. Doing IVF or ICSI, the sperm antibodies are irrelevant, and so we avoid that problem. The other issue, as I said, with the tubal ligation issue, once you've reversed it, you then have a contraceptive problem. And most men, having had an operation on their genitalia to be sterilised, an operation on their genitalia to be unsterilised, are pretty reluctant to have a third operation to prevent a pregnancy in the future. So that's a whole collection of things that people have asked me over time. I hope they may be individually helpful, but I'm more than happy to answer any further questions if anybody would like to send them in to my email address, which is on my website. And don't forget that you can access all the previous episodes by going to our website, www.theivfjourney.com, and select IVF Journey Podcast from the navigation menu.
Thank you for listening to the IVF Journey with Dr. Michael Chapman, the podcast which helps couples negotiate their way through the IVF journey, all the way to parenthood. You can also ask questions by contacting Dr. Chapman's rooms on 1800 111 483 or by emailing him michael.chapman@ivf.com.au.